Sponsored in part by Pediatric Associates of Dallas. Pediatric Associates of Dallas has been providing excellence in pediatric medicine since 1971. PAD has locations in Dallas and Plano and is now open 7 days a week because taking care of kids is what we do.
The following content is not intended as a substitute for professional legal advice, medical advice, diagnosis, or treatment. Always seek the advice of your attorney, advocate, physician, or other qualified health provider with any questions you may have regarding any medical or educational concerns.
Hello, and welcome to another episode of Empower Dyslexia podcast and show. I'm Rachel Chambers.
And I'm Stephen Yearout.
And we're here to help you be a better partner in education. On the show, we talk about dyslexia and related disorders, interventions, research in the field. What else do we talk about? Special education policy at the state and federal level. And we also interview experts and just people that have life experiences with dyslexia and the related disorders. So thank you for joining us today. We have a great show. We have
your significant other today.
Yes. We have Dr. Dreiling on. Do we want to do this slide right here? You guys know where to find us. We're on Twitch, Twitter,
Apple Music, Google
iTunes.
Play, iTunes, you name it. All of our favorite apps for you to watch and listen to podcasts. Obviously, we're on Facebook Live and YouTube Live every Thursday at 11.
Every Thursday at 11. And then also remember to like us and to subscribe to our channels because that really helps us out with sponsors, and we need more sponsors for the show.
Make sure you give us some comments so we know that we're on the right track. Mm-hmm. Well, today, as we said, we have your significant other.
Ta-da!
The man, the myth, Dr.
The legendary.
Yes. So Dr. Dreiling studied or was undergrad at UT Austin, correct?
Correct.
And he studied biomedical ethics and film history. You then went on to UT Southwestern, where you fell in love with pediatrics.
Mm-hmm. Yep, I did. I started medical school thinking I was going to be a surgeon, and I did pediatrics and loved it, and that was it. And never looked back.
So can you tell our audience a little bit about yourself?
So I'm a general pediatrician. After training, I stayed on faculty at the medical school for a couple of years and then went into private practice, where I've been for the past 17 years in central Dallas. So I take care of children from birth all the way through college if they want to stay.
So, and I will say that his office, Pediatric Associates of Dallas, is one of our sponsors. They're one of our, what do you call it?
Well, they've been one of our sponsors from
since
the beginning.
So they've had faith in us and are very supportive of us. So we're so lucky to have one of the pediatricians in that big office on the show. We'd like to get some more from your office on. I know how busy your schedules are, though. You work all the time. But so anything else you can tell us about yourself?
I am an ADHD patient myself.
Oh, okay.
And so understand this from multiple levels, but greatly enjoy taking care of patients with ADHD, which is what I believe we're mostly going to talk about today.
Yes.
Yeah, so that's our topic today, ADD, ADHD. From what I've been told, they now just say ADHD, and they lump that as the umbrella term, and then they have ADHD, non-attentive or attentive, or hyperattentive.
ADHD with three subtypes, predominantly inattentive, predominantly hyperactive, or combined, which is the very large middle, which most patients fit into.
Awesome. So at your office, when a patient comes in and the parents are saying, hey, we we have a
Concern.
concern that our child may be ADD, ADHD, whatever they say. Is there certain certain tests or screeners that you provide or can go through?
Sure. It depends on whether the concern is coming primarily from the parent or from the school. A lot of times, if school is raising these issues, they've already provided the parent with some sort of screener. But if not, if they come to me with the general question, then a straightforward way to start is with a standardized questionnaire. The one that I recommend that we use is the Vanderbilt Questionnaire.
I think we have a slide for that. So can you kind of walk us through that, the Vanderbilt?
Yeah, so the Vanderbilt, there are two of them, one for parents to fill out and one for teachers or caregivers if the child's in daycare, for example. It has a series of questions that are somewhat randomly organized so that it gets a clearer picture of the child, and it's designed to tease out things like attention issues, hyperactivity from possible mood disorders, oppositional defiant behavior, etc. It's a screening tool. It helps us get pointed in the right direction of what we should do with the child.
So you're really looking at different environments of that child. That's the reason why you use two different, a parent version and a teacher or another caregiver type.
Right. For example, a child can appear to have symptoms that would be consistent with ADHD that are actually more primarily caused by mood disorder or by sleep difficulties, et cetera, or the other way around, that the child is mostly presenting with mood type of pictures, but the primary problem is untreated ADHD, causing them to be anxious or depressed, et cetera. So the Vanderbilt helps to sort out, where the areas of concern might be so that you can, organize your approach in some sensible way.
Now, I've also heard this two-part. I've also heard that of course, parents fill it out, of course, but and teachers are recommended to fill it out, but anybody who is a caregiver or has spent any amount of time with the child, like grandparents, whoever, can fill this out. And sometimes they say the more the merrier, so we have a better idea of what's going on.
Absolutely. Yeah. The questionnaire is labeled parent and teacher, but yeah, parent really extrapolates to family members who spend a lot of time with the child in the home environment, and teachers to anyone that spends a lot of time with the child in a school or child care environment would be extrapolatable.
So
for my son, he was old enough to understand what the questions meant, or we read them to him. I did one for him, my wife did one for him, my parents did one, teachers did one, but we actually had him do his own, just to kind of see if all the answers matched up, and then took that.
Yeah, anything can be helpful. But when we have a lot of people, that helps to identify outliers with folks that for example, occasionally have done many of the screeners, know what it's for, know what the questions mean, already have formed an opinion about the child, and it might tailor their answers a little bit. So when there's an outlier that's considerably different than everyone else, then we can take that into account.
Yeah, that makes sense. So, and this is, we have on here, it is a screener. The Vanderbilt is just a screener. It is not a diagnostic. It does not provide a diagnosis, correct?
Correct.
Yeah.
It's frequently used by diagnosticians. It's just part of the data, but it's not as simple as, if you have a certain score on a certain section of the Vanderbilt, we apply a diagnosis of ADHD. It's just a small piece of what is done, and it's very useful as an initial screening tool to even see, whether that should be pursued at all.
Okay. And so, what do you actually need to get the diagnosis of ADHD or ADD?
In children, we really try to have a comprehensive look at the child. Ideally, they have complete educational diagnostics done, not only looking at the ADHD piece, but any other concomitant learning disorders that might be there. Because in our experience, when a child genuinely is ADHD, they almost always have some other learning difference. And since we're looking at them at a very young age, we want to identify those things as young as possible so that we intervene. If a child's dyslexic and ADHD and we nail down the ADHD piece but miss the dyslexia, then we missed a really good opportunity to get it at the beginning.
At the young age. Yeah.
Right.
And so at your office, I know because my kids go there, you guys have, I think it's called Ages and Stages. It's a questionnaire that the parents fill out at every health check, like starting from 2 months on up to
60 months, 5 years.
5 years old. Do some of those look for, developmental delays or,
Yeah,
and does every office do this?
The Ages and Stages is designed to catch early signs of delays in gross motor skills, fine motor skills, communication, personal social interaction, and catch it as early as possible, kind of graded roughly against research standards as good, keep an eye on it sort of, and clearly behind. And so in those areas, we can catch the child very young and start to intervene.
So if you have a child that is, maybe he's not crawling, and he's, say 18 months and he's not talking or whatever, and he's, again, 18 months, 2 years, what do you then suggest to your parents to do? Or what do you do as an office?
In Texas, if they're under 3 years old, then we encourage the parents to use the Early Childhood Intervention System, the ECI, which is a useful way for the child to be followed very early on, evaluated more comprehensively, referred to other services.
And they can Google that. So early childhood intervention.
Early childhood intervention.
The state pays for it.
Or ECI.
Yeah, ECI. Google it.
It's state funded but locally administered. So each city or community may deliver it in a different way.
Okay. And then you also have like a vision chart, you had said?
Our office does indirect vision screener. It's actually a device that takes the measurements off the child's eyes, which we do at 1, 2, and 3 years old before the children can participate in a Snellen Chart or reading chart. And so at 4, we attempt to do the Snellen Chart, which most people will be familiar with, is the line of letters, and you read the lowest line you can. Of course, one major problem is if the child's dyslexic, or at which point at 4 they can have a lot of trouble recognizing letters. So sometimes we get a hint of an opportunity to intervene as simple as the 4-year vision check. When the child can't perform it, that's a perfect opportunity for us to ask, how much have you worked with letters with him or her, and have they been having issues? It's not the primary reason we do it, obviously, but if you're carefully paying attention, it's a potential red flag.
Yeah.
Yes.
Cool. I just wanted to go through that because I don't know if every office, does that. And I think it's kind of cool that you guys do. So, okay. So, we've made the diagnosis of ADHD, right? They've done more educational testing. They did the Vanderbilt. They did more educational testing. They found out that they have ADHD or ADD.
Let's flip this around just a second.
Okay.
So, so like you were saying, you've made the diagnosis, or you've said, yes, this child does have ADHD. And then you start making your plan on how do you treat, is that correct word? Treat this condition. I know a lot of parents are very apprehensive on putting their child on any type of medication. How do you handle that piece of it?
Well, when I sit down with the family in consultation, so we set up a lot of time to talk once this diagnosis has been made, and we talk about it on 2 fronts, possible medical intervention and non-medical intervention. So medical intervention being a prescription medicine of some sort, or in some cases nutritional supplements. There's different approaches. versus everything else that they need to do. As a physician, I can focus just on the medicine piece, or I can also advocate, which I try to do quite a bit, helping them make sure they initiate the proper modalities through school, letting them know what their rights are, letting them know who they should be talking to, what the standards should be, and even in some cases, even a step before doing the evaluation through the school district. And then once we've talked about that, then we go to the medical piece and we talk about what the treatment options are.
And we'll talk about how do you get that evaluation done through the school at the very end. So you sit down, you talk, okay, here's the two options. You got the medical piece of it, which is the medicine, you said some dietary supplements. I know that there's a group of parents out there that are absolutely staunch. I'm not giving medicine to my child at all. We're going to do this through, dietary measures. Is there any, and I know this is very controversial for a lot of people, but is there any validation or validity to we're just going to treat it with diet when it's truly ADD, ADHD?
Right. Evidence is quite clear that medical therapy is better than dietary implementations, strictly behavioral modifications, cognitive behavioral therapy, et cetera, particularly in the younger children who, for example, are not going to be able to participate in things such as cognitive behavioral therapy. In my experience, there's a lot of fear out in the community that comes from a lot of different angles about how we medically treat ADHD. And frankly, a lot of the time it's because the parent themselves is ADHD and had a negative experience with medication when they were a child, or their parent didn't want to do it, et cetera. Plus, just quite understandably, any parent's apprehension at putting their child on a medication when they're not sick, quote unquote, with infection or something obvious.
Well, I mean, I have to admit, I was very, when the school said my 4-year-old needed to be on stimulants, I was like, no, we're not doing that. And so, Chris and I talked about it, or Dr. Dreiling and I talked about it, and we decided to go the Strattera route because that was the non-stimulant route. And it did help for a little while.
Right.
And then when he got a little bit older and I was more comfortable, it has to be, the parent has to be comfortable and trusting, I think, of their pediatrician or whatever physician is prescribing the medication. And then I was comfortable and saw that he still needed help. I was like, okay, we'll try a little dose. Start low. Start very, very low,
Well, I'm a physician. I start children on these medications many times a year, many times a week in some cases. Yet when my child was at that point where we're trying to make the decision to do it, I felt reticence. It's a natural instinct. I commend parents for being worried about it. That means you're doing your job. You're not just blindly following or looking for a shortcut. You're really wanting to have information and really do it. So my job is making sure that the parents are getting the whole picture. I can render my own opinions about these things, but I also, as a allopathic physician, which is the MDs and allopath, we believe in evidence-based medicine. In so much as you can, prove it. Right. And so whatever things that we've demonstrated to clearly work, I talk to the parents about that while also simultaneously recognizing that there's things that just haven't been studied yet. So they may be effective and we just haven't covered that yet. So they may help. And every single patient is different and their brain's going to react differently to different things. So the overall idea is get confident about the diagnosis as much as we possibly can. Have informed approach to the different options, and then decide as a team what to try with the only commitment being trying it, which is what I impress upon the parents. You know, if we decide that we're going to try a stimulant medication, for example, we're not saying you have to be on it for a year. We're saying you have to be on it for sometimes a few days to have an idea of whether we're on the right track or not. And when the child is thriving, it sells itself.
Rachel, you and I went to a lunch and learn where I first really started understanding about ADD, ADHD, executive function issues. And I was sitting there and I was going, this is the missing piece, because we already had diagnosed my son with dyslexia, and he was going through intervention. It just wasn't clicking. Something wasn't there was something else that was missing.
They didn't do a full eval.
No, but
Obviously. sounds like.
Once we figured that piece out and we made the decision to go ahead and put him on medicine, two things. Just like you were talking about, just a few days, literally within a few hours of us giving him his medication, we saw a completely different kid. Mm-hmm. He wasn't the lethargic, the typical, this kid is completely zoned out or zombied out. Mm-hmm. It brought him down to normal. Mm-hmm. And when I mean normal, the kid that I know and love when he's not bouncing off the walls, right? To add to that, his dyslexia teacher came to Amy and I and said, thank you so much for continuing to search for what else was going on. That was the missing piece, because he is doing so well in school now in my class. That was it. That was the piece that we were missing.
Well, and so many people that we've had on the show have said it's when a child has dyslexia, 60%.
I think it's 80%.
70, 80% of the time they have another related disorder, or some of them. Well, I know Dr. Housen said, I believe, is if they have dyslexia, they are 60% sure, or whatever word I'm trying to think of having ADHD. So that's why we stress doing the full evaluation, because you may try to help by starting the dyslexia intervention, but if they can't focus on getting the intervention into their brain because they're all over the place with ADHD, then what good is the intervention? They need to be able to focus to get the most out of the intervention.
Right.
So anyways, I digress.
So we talked about, or briefly mentioned, non-stimulant and stimulant medication. Mm-hmm. Can you kind of talk to that?
Sure.
Why would you use stimulant over non-stimulant in a child?
So when I'm talking to a family about this piece, when we talk about the medication, then I break it down very simply. There are two medical approaches, what we call the stimulant medications, which is a bit of a misnomer because the medications are actually stimulating, quote unquote, to a patient who doesn't have ADHD, ironically. This was the effect that these medications caused on people when they were originally studied, and so they were described as stimulants. And then, as time went by, found that it had this very positive effect on ADHD folks, which quite opposite of what normally one would think of as stimulation, where they actually are calmer, more organized in their thoughts and body. So, first of all, it's a little bit of an unappealing name, stimulants.
Right.
And then, by definition, everything else would be the non-stimulants. So the most commonly used non-stimulant is a medicine called Strattera, which Rachel referred to earlier, which we tried our son on first. And then stimulants break down basically into two big categories, which are the methylphenidate medications, of which Ritalin is the brand name that most people have heard of, which dates back decades, and amphetamine class meds. Dexedrine was one of the very original ones. Adderall, a lot of folks have heard the names, and Vyvanse, which is one that most adults with ADHD take. And so, in a simple sense, what we know is for the grand majority of patients, stimulants clearly work better than non-stimulants. There are a few other other than Strattera stimulants, but they're sort of blunt tools, not very effective, usually used in conjunction with stimulants. So Strattera was the first non-stimulant that was really, we had some genuine hope would have the same kind of effects on ADHD without the downsides of the stimulants we'll talk about in a minute. So really it comes down to that. So I'll say stimulants and non-stimulants, although if we really want the best chance of succeeding, we would start with the stimulants and go to the non-stimulants if we had that small percentage of patients that just simply don't tolerate them well. And then take it from there.
So how do you decide with the family what, okay, so say they're not 4 years old like our son was. Say they're 8 or 9 years old, and they're like, yeah, they're still bouncing all over the walls. They're having a hard time focusing on their schoolwork. They can't get it done, their schoolwork done. They're kind of having a hard time in school now. They're not doing well on their tests. How do you recommend which stimulant to what child, I guess, with the family, of course? I know it's a family decision.
Sure.
And physician, or, you work together.
One of the reasons that ADHD is now characterized as an overall disorder with subtypes is partially so that we get away from the idea that if you have ADHD, you take one medication. If you have ADD, you take another one. Generally, the methylphenidate class, the Ritalin class, is more effective with fewer side effects in younger patients, and the amphetamine class is more effective with fewer side effects in adults. So if I'm starting with a 4, 5, 6-year-old, I'm going to recommend that we try methylphenidate first. And if I'm starting with a teenager, then I'm going to recommend that we start with amphetamine first, and then see how we do. There are, of course, exceptions with adults who do better on methylphenidates and occasionally younger children who do better on amphetamines. So we just have to be prepared to simply make a choice of the fork in the road. There's only two, and start at a place and then very carefully watch what our response is and adjust.
So you guys have made the decision to start stimulants. What are some of the side effects that parents need to look out for, or even teachers, that you commonly see?
The main one that we see close to universally in patients at all ages is some amount of appetite suppression. And that sometimes in adults is very minimal, which is disappointing to a lot of adults who'd love to have the appetite suppressed a little bit more.
Right.
Yeah, exactly. But for the younger the patient, generally, the more of that we can see. And so as a team, you have to sort of set a standard of what you can tolerate and what you can't. For example, if I start a child on a medication that's designed to last and cover the entire school day, I can't tolerate them not eating lunch. Now, might they eat less at lunch on a day they take the medication versus a day they don't? Yes. And if they particularly are given an opportunity to snack in the afternoon and definitely when they get off of school, then their caloric intake is going to be the same. They're just going to distribute it somewhat differently. But if they don't eat lunch at all, then their blood sugar is going to get too low by the afternoon, and when their medicine wears off, they can feel pretty yucky.
That's when they have the crash.
Yeah, it can have bad headaches or other sorts of things. So that's one of the first things I tell the parents is that somebody has to be monitoring this child and seeing what they're doing at lunch. Not just seeing if the food comes home in the lunch pail or whatever, but also is somebody watching, are they actually eating? And if they don't, we can't keep doing what we're doing.
We had to do that with Aiden because he's so thin. Mm-hmm. We had to make sure that the principal or whoever had lunch duty was making sure, keeping an eye on him, that he was eating. Because at the very beginning, he wouldn't eat. He was like, I don't feel like eating. Like, you have to eat, making sure that he ate. But yeah.
Some people experience that in the same way that some folks experience hypoglycemia or low blood sugar. You don't have an appetite. You don't have an instinct to go eat, but if you actually take a bite, it kind of kicks things into gear. So some of these kids, if they just have a rhythm to put a bite in their mouth, then their appetite gets rolling. Others, though, it suppresses them completely, and they have no desire to eat at all, and it actually is unpleasant to them at the moment. And that would be a rate limiting step.
Yeah.
That's when you would look at going to a non-stimulant version
Or just
something,
taper down, I
something
would think.
different.
Or the other stimulant, or a different formulation that is designed to come down even lower at lunch.
So what I'm hearing you say is just because they're in the stimulant category, the formulation of the medicines are completely different and can have different effects on your body. So making sure that you are watching what's going on, the school's watching what's going on with your child is huge for a parent and for the physician to make sure that you're on the right dose and on the right medication.
Right. So of those two classes, the methylphenidate and the amphetamine, folks hear all these brand names thrown about and don't really realize that they're just variations on those two themes. Excuse me. So the old days, when I was a child, the way that this was done was you take Ritalin in the morning, and it would have an effect kind of peaking at about 2 to 2.5 hours in and taper down by 4 to 5 hours. Then you'd go to the school nurse and take a second one, and that would cover your afternoon. And you have a pretty deep valley in between. The improvements that have been made in the medications over the years are release systems that the child can just take, or the adult can just take in the morning. And most of them are designed to have a peak in the mid-morning, dip a little at lunch, and come back up in the afternoon for the younger kids for this exact strategy. But say, for example, I try a child on that and they're just doing beautifully, except they're not eating lunch. Well, that's a child we may actually choose to go back to the old school way and do the short acting so that we have more of a dip at lunch, and then just have to get the timing right. So all of these things are potential options. But in a perfect world, the child just simply takes something with breakfast before they leave the house and then doesn't have to do anything at school except succeed.
So, and then I know some parents, well, how do parents and teachers know when the child is taking maybe too much? I mean, what are some of the negative side effects that some of the stimulants have other than appetite suppression that they need to be looking out for? Because it's a fine line, I feel like, with the stimulants. You have to get it just about right. You don't want to go over too much. You don't want to you want it just right. So it's like Goldilocks, the three bears.
Yeah, and this was one of the errors that was made in how we treated kids back in the 70s and 80s, was arbitrarily, we now know, deciding, okay, well, you're 12 and you weigh 100 pounds and you have very severe ADHD, so this formulates together to a recommendation to start at X dose of Ritalin. Well, that might have been catastrophically too high on a given patient. So if a patient has ADHD genuinely, but is on too high a dose of medication, they go too far in the opposite direction. They become what we call hyper-focused and just so zeroed in on what they're doing that sometimes they can develop a flat affect or actually find it difficult to even speak to a person engaging them. They're locked in. And this is what folks would typically call the so-called zombie effect, where you're just so locked in. It's unpleasant for the patient too, as you might expect.
Right.
The way we avoid that now is, no matter who you are, if you're 4 or you're 24, we start you on the lowest possible dose of the medication and work our way up. And that's how you almost always avoid, that really unpleasant effect. Sometimes as you're titrating up, you go just a bit too high, and then the person is clearly more focused than they want to be, but they're not all the way zombied out, not so unpleasant. And this is the thing I hear from the parents all the time. Said, well, when I was a kid, they started me on the medicine and turned me into a zombie, and my parents were horrified, and they said, I never take them off of that. Or even these days, if a practitioner uses an old school approach, they may create these horror stories, these bad anecdotes that circulate about. But if you do your job right, A, try and diagnose the patient and get it right at the beginning, and B, start slowly, carefully, and work your way up, then you avoid those kinds of stories and experiences.
When we talked the other day, when we were preparing for the show, I had asked a question about how parents' concerns were that the child is going to become addicted to the medicine and never be able to come off of it. And can you please talk about that a little bit, your explanation on that?
Sure. Well, these patients have different brain and body chemistry. This is what we know about them. They literally do not respond to these medications the same as someone who does not have ADHD. So if you do not have ADHD and you take amphetamines, then you're going to have the effects you would think of someone who's taking amphetamines or speed as a common crystal meth, all these different categories. Very jazzed up, a bit of a high, quote unquote, unable to go to sleep until 4 a.m, eating nothing all day long, etc. But the ADHD person who has different brain chemistry, who takes this medication, comes to the midline more and reacts more in the typical or normal way you would think someone would be. So they don't get high on it, and their body doesn't develop dependency on it in the way that someone who does not have ADHD does. And again, we start low and work our way up. So ADHD patients taking sometimes remarkably what we would consider high doses of something such as amphetamine can take it one day, not take it another day, and have no consequences or withdrawal symptoms or that sort of thing. So it's a completely different approach. In the same way that someone who is very, very, very depressed takes a medication that might put someone normal into an extraordinarily elevated mood, just kind of makes them feel sort of normal because their brain chemistry is different, leading them to be so very depressed. And it's the same thing with the ADHD.
I appreciate that explanation. At least that way it can help some of these parents, calm some of their worries.
Mm-hmm.
Oh, sure.
Because that's a typical response from parents that we talk to about ADHD medicine.
Right.
So,
Yeah, and so I explained to them, well, this is nuts. You're talking about giving this powerful medication that I keep hearing on the news that people are addicted to all the time. I watched Breaking Bad. You want me to put my kiddo on that? What's wrong with you? But then when you really understand that all meds are not the same for all people, you can get comfortable with it. My job as the physician is to understand that and understand how these things are going to sound to people.
Right.
Empathize with them as a parent and say, oh yeah, if that's superficially, it sounds utterly nuts, but it isn't.
We're all neurodiverse.
Yes, extremely neurodiverse.
So these children, or let's say children, that have ADHD, do they ever outgrow it?
What changes for a lot of them is how the brain chemistry manifests as they get older, but it doesn't go away. When you have a fundamental difference in how your brain works, it's a fundamental difference. You're born with it, you have it forever, okay? But one of the misunderstandings that, again, led in the old days to feel like kids outgrew it, quote unquote, is that in a lot of patients, boys particularly, there's a huge element of hyperactivity and impulsivity when they're little that actually fades as they get older, whether they take medication or not. However, the underlying attention problems, focus problems, executive function challenges, organization, et cetera, don't go anywhere. So it was unfortunate because you'd have boys that primarily got put on the medications when they were younger because they were running around the top of the furniture, and that improved everything and their school performance improved. But as they got older, they weren't hyper anymore, and so everyone said, well, they outgrew it, so now we don't take the meds anymore, and then their school performance cratered. And sometimes that got picked up on and sometimes it didn't. Mm-hmm. But so it is true that how it presents can change depending on the patient, but you don't outgrow this. Mm-hmm. Okay. But I take pains to tell people this isn't a disease in the way you think of, say, pneumonia. Okay, you've got pneumonia, you need to take an antibiotic or you might die. Straightforward. I compare this more to, say, having nasal allergies. If you have bad nasal allergies, your quality of life is not good, particularly in certain seasons of the year. If I don't treat it, you'll power through, but you may not sleep well. You may be distracted by all this unpleasantness. You may not be able to go play outside because you're sneezing your head off. I can improve your quality of life immensely. If we don't treat someone with ADHD, it's not going to literally kill them, but the entire quality of their life is going to be lower. And for children, pretty much in all dimensions, every moment they're awake, adults are asking them to do things they can't do or have to work incredibly hard to do. And that is an unbelievably unpleasant experience for the child. And it starts from the moment they get out of bed, not even be able to get themselves ready for school like they want, all the way until they go to bed and having trouble getting ready for bed the proper way and deal with these struggles at school and at home all the time. It produces a very stressed out, anxious, depressed child very frequently. And so we can improve that immensely, or even if we have a chance to improve it immensely, we really should think hard about exploring that. And if it doesn't go well, we bail. If they're not having the response we want, or if they're having side effects that we don't tolerate, then we're out. And the medicine's out of their system within 3 or 4 days completely, and you're done. So it's the commitment, the leap that the parents often have to make is just saying, okay, I have this child, it's that kid who might need to take ADHD medications. But if we get past that and get to the brass ring, which is a much happier child, a much more successful child, a much more well-adjusted child, and all the secondary benefits that come to the entire family of not having to struggle with that child the whole time, well, I advocate for folks that they should think really hard about at least trying it.
So to kind of circle back, we're going to do a screener. We're going to make sure that we talk to our physician and give them the full picture of the child. We're not talking about behavioral issues.
Modification.
Yeah, this is not a behavior pill or behavior modification way to modify behavior issues. We're talking about a child that has been diagnosed with a medical issue that can be treated very effectively with these two different types of medication. So as we say, being an informed partner in education, but at this point we're being an informed partner in our medical side of this that we want to do. Same thing we would do, like you were talking about with allergies. We give kids allergy medicine all the time. So we need to kind of look at it from that perspective in the quality of life and how this child is going to not be in that trauma from the time that they wake up to the time that they go to bed, correct?
Right. And if you have allergies, you can go run to the pharmacy and grab some Zyrtec and just see how you do. So these are more powerful medications. They need to be very carefully managed by someone who's very experienced in it, a physician or a psychiatrist, a general practitioner or a psychiatrist who is also a physician, of course. But it's the same basic idea in that it's a quality of life issue. If you live out on a desert island and you have no schedule and it doesn't matter how long it takes you to get the coconut down and crack it open and you're just going to paint all day long, you don't need to be treated for ADHD.
Right.
But the world we live in, all schools, even ones that have some flexibility like Montessori, and your experience with the patient at home, whether they're your child, whether they're your spouse, whether they're whatever, is very likely going to be much, much better and much, much more efficient if you're treated.
I know that it definitely affects all areas of your life. Doesn't matter if you're in preschool or, like you were saying, you're married. It affects your marriage if you have a spouse that's is not ADD, ADHD, and the other one is. That can greatly affect the relationship.
Or even two ADHD. You probably get each other more. But But yeah, I mean, it's hard to get anything accomplished, communication and,
And the stimulant medicines aren't perfect. They're not ideal.
I wish
It's
there
not
was
a
something
fix-all.
perfect.
Well, and even the way they work, it's unfortunately, they come on board and they're gone by the end of the day.
Right.
So the holy grail is to find a medication that gets these brain chemistry differences to an even place and stays there 24/7. And trust me, there's thousands of people working on that and have been for a very long time trying to find a safe, effective medication that does that. We haven't found that. What we have, the best tool we have, is the stimulants that change that chemistry temporarily to a good place, but unfortunately then disappears by the end of the day. And so that's part of how we counsel the parents. For example, a child, when they're treated at first, I mean, they have the best day of school their whole life. It's the first time they came home and didn't have a whole bunch of reds. They've got all greens, and they enjoyed learning. And then it disappears on them by 3 or 4 o'clock in the afternoon. That's tough.
Yeah.
You know, children can become tearful. They can become angry. And so that's part of the overall coaching. We prepare the parents for that and say, you know, leave them some room, give them some days and weeks to adjust, to get used to that, you know, that good effect coming on and coming off. And it's unfortunately just part of the process right now. But, you know, I'm quite hopeful that in my practice lifetime, we'll have even more precise tools than we do now. But the tool's pretty darn good.
Well, that is great information. Thank you so much for coming on the show.
So is there anything else?
No.
Okay. So as we always like to recommend, go, if you think there's your child, you think there's a problem with your child, educationally speaking, or student, you know, go and have them request that they have a full evaluation. This will identify what the issue is and then help your child succeed. You know, match the intervention with the learning difference or disability. And if they have ADHD, you know, then they go see their pediatrician or psychiatrist to start down that road.
You need to get a full overview of what actually is going on with your child.
Oh, and I found out, this is new information I just found out. So when you ask for a full evaluation and you're suspecting ADHD, you need to ask, a lot of times they'll just do, well, this is what one of the diagnosticians told me. A lot of times they'll just do a partial. And I'm not really sure what she meant by partial, but you need to ask for, yes, I think my child has ADHD, and I want you to do a full evaluation compared with the G scores. So that way they know that what questions ended up being more valid than other questions, or something like that. I would love to have her on the show to explain that a little bit more, because it was really fascinating. I didn't have enough time at that time to, you know, get more details from her. But I do know that. Ask for G scores,
So
whatever that means.
the process for getting this evaluation from your ISD, you can go to our website, www.empowerdyslexia.info. And you can download one of the templates off of our website, fill in your information, turn this into your school counselor, and that gets the process started. They do have a time limit within that window. Once you turn in that application or that paperwork to get your child evaluated, they do have a time limit that they have to meet. So make sure that you do that as soon as possible, because we are coming up on school starting again. So
Yes. So you can go to our website. Did you already say that?
Yep.
Okay, go to our website and look for that kind of stuff. And then and view any of the other podcasts that we have. That we house them all there, and on YouTube and on Facebook. So thank you so much for joining us today. We hope you enjoyed the show. And thank you, Dr. Dreiling, for coming on the show and telling us all you know about ADHD.
You're welcome.
It
was
was
a
very
pleasure.
good. Yay.
I learned a lot more about it and how to treat it and
Yeah.
why you do certain things. It definitely cleared up some
Just
misnomers
misinformation.
that I've been told that I kind of had in the back of my head also. So thank you very much.
Good. All right. Y'all check us out next time.
See you there.